topic. So my talk centers on hydrops fetalis, and I will mainly concentrate on genetic testing, mainly because going into too much detail about this condition, I think that's probably more likely. So just very briefly, I'm sure we're all aware that hydrops is a pathologic condition which is defined of at least two abnormal fluid collections in the fetus, and that entails pleural effusions, pericardial effusions, ascites, or generalized skin edema. Placentamegaly and polyhydramnios can be present, but they're not diagnostic of this condition. It usually is diagnosed in an asymptomatic patient on an antenatal ultrasound, and very often it's sort of we put the scan probe on and we suddenly see that the baby is hydropic. Rarely do we suspect it because of other symptoms. Only in severe cases of polyhydramnios, the mother might present with abdominal distension, discomfort, or shortness of breath. And even rarer than that, the mother might present with mirror syndrome and signs and symptoms of severe preeclampsia. So very often we're sometimes surprised by this diagnosis. These are the typical ultrasound features that we see. So we can see evidence of pleural effusion, ascites, skin edema on our fetus, and most of us will probably be able to pick this up when we put a scan probe on. Now my talk is going to mainly center around non-immune hydrops fetalis, but I do have a couple of slides in the beginning just to talk a little bit about immune fetal hydrops, which is currently only less than 10% of the cases, and has dropped dramatically after the introduction of antenatal anti-D injection. Immune fetal hydrops, of course, we are aware, is mainly due to red blood cell alloimmunization, whereas non-immune hydrops fetalis result from a multitude of different conditions. So traditionally, it's due to immune fetal hydrops is due to APO and rhesus factor incompatibility, and the most common one, of course, that we're aware of is anti-D. But there are other antibodies that are significant, and they're becoming more and more significant now because we don't see much of anti-D anymore. And they're our anti-K, anti-small c, anti-E, anti-C, anti-FYA, and anti-FYB. So the incidence of hemolytic disease of the fetus and the newborn has dramatically decreased from about 16% to less than 1% after we started giving anti-D prophylaxis. And currently only about 0.5 to 1% of pregnancies are actually sensitized by other red blood cell antigens. Now we heard already from Professor John Hyatt yesterday that there is quite good non-invasive prenatal testing available for rhesus factor, which can be done as cell-free DNA testing for fetal rhesus genotype, which is very reliable with a good sensitivity of 95% and a specificity of 98%. And there are other assays available for other red cell antibodies that use next generation sequencing based NIPT assays, a quantitative counting template looking at other genotypes such as C, small c and big C, E, K, and FYA, and they have shown a sensitivity and specificity of 100%, so are virtually diagnostic. So that, of course, makes it much easier to manage these pregnancies these days because we can non-invasively determine the fetus status, and we can then concentrate on looking after our pregnancies deemed at risk with either maternal antibody titer monitoring and then NCA+V monitoring once the threshold is reached for those antibodies that require threshold, and then treatment of the fetus with fetal blood sampling or in utero transfusion if we confirm fetal anemia. The outcome of these pregnancies has significantly improved. So this is a study from the Netherlands comparing the time frame between 1988 to 2000 with the time frame of 2001 and 2015, and they have shown that the overall perinatal survival after in utero transfusion has increased in this time frame from 88.6 to over 97%. Okay. So generally, once we manage to identify these pregnancies, we can usually treat them, monitor them well, and they tend to have good outcome. Now, the mainstay of my talk, as I said, is non-immune fetal hydrops, and this is a flowchart taken from the recent talk article in 2023. And it's quite a nice paper because it gives a practical guide for obstetricians, so I think most of us will find some useful information in there. It shows basically that this is quite a complex condition which can be caused by many different physiological mechanisms. So there can be inborn metabolic disorders, hematological disorders, infections. There can be cardiovascular anomalies, hematological disorders, and have venous return. And all of these can lead either to hepatic failure, cardiac failure, which in turn leads to a high plasma oncotic pressure, increased central venous pressure, reduced lymphatic flow, and interstitial increased fluid, which eventually presents as non-immune fetal hydrops. So quite a complicated pathway, and you can see that there are many different factors which can lead to this. And being from Europe, I use this analogy. Some of you might be familiar with that. We say all roads lead to Rome, okay, yeah? And the same is certainly true for fetal hydrops as well. So you can see a list of all the different conditions on the right that I purposely made a bit small because I don't expect you guys to remember, but it's just important to note that actually fetal hydrops is a common endpoint of many, many different conditions. So it is not a single disease, it's actually a manifestation of many different diseases. And that, of course, makes management and testing and prognostication for this condition extremely challenging. So the etiology currently, when we're looking at the literature, can be determined in roughly about 60 to 85% of cases, and that is either pre or postnatal diagnosed. The remaining cases still are considered idiopathic, that means we have no answer, okay? And as we showed, it is associated with a broad spectrum of disorders. The key issues are mainly to identify cases caused by disorders that we can treat in utero, deliver the fetus when the benefits of prolonging pregnancy are exceeded by the risk of imminent fetal demise, and identify disorders at risk of recurrence so that we can adequately counsel our women on the management of their future pregnancies. This is the general approach, and I will not go through this in much detail because I will concentrate mostly on the genetic testing. But of course, these cases are usually referred to a tertiary fetal medicine unit. MDT input is generally required with a fetal medicine specialist, geneticist, genetic counselor, possibly palliative care team, and relevant subspecialty depending on the etiology. A detailed fetal surveys should be undertaken to identify structural problems on the baby, and especially concentrating on fetal echocardiography. MCA-PSV should be measured to identify the anemic fetus, which might require immediate in utero transfusion. Lab investigations of the mother usually concentrate on whole blood count, MCV to exclude thalassemia, red cell antibody status, possibly infection screening, and maybe Klein-Howell to exclude fetal maternal hemorrhage. Testing for infection, we heard from Wen-Chan just now on the background of IUGR is similar, so we would usually send a CMV, toxo, and probably a parvovirus screen, either on maternal serology or amniotic fluid. And if we're putting a needle inside and we're performing a paracentesis or thoracocentesis, we can also send these samples for fluid testing, morphology, and fluid profile, as well as differential count. So the mainstay of my talk is, of course, genetic testing, which we usually perform in most of these cases unless the patient declines. And this is, of course, our traditional karyotype. So traditionally, we used to perform karyotyping for all our patients. And karyotyping yields about a 29% or almost 30% diagnosis antenatally for all fetal hydrops cases. And we can see the typical diagnosis that we get from this trisomy 21, Turner syndrome, trisomy 18. Now, and of course some other less common conditions. Now, this is particularly true if we look at the first trimester of pregnancy, so there is quite a difference in when we actually diagnose the fetal hydrops, what is the yield of this investigation. And abnormal karyotype in this paper in the first trimester can be identified in up to about 65% of cases, but gets much lower if we diagnose fetal hydrops later on in pregnancy. And this is a paper from St. George's looking at fetal hydrops causes through the different trimesters of pregnancy, which similarly confirms this finding that chromosomal problems detectable by karyotype or PCR in the first trimester can be as high as 70%, but in the second and third trimester go as low as 21.4%. So karyotype we rarely perform these days on its own. So what is the additional yield of CMA? And I think we've seen this many times. This landmark paper showed that when we perform a CMA fetuses and structural anomalies, we usually get about a 6% incremental yield. No anomalies is about a 1.7% additional yield. But does this hold true for fetal hydrops as well? Well, maybe not. Okay. So this is the paper from the UCSF by Teresa Sparks' group, and they specifically concentrated on looking at the utility of CMA for the diagnosis and cases of non-immune fetal hydrops. And they had 131 cases undergoing genetic testing, and of those, 44 had a CMA performed, and they only found one abnormal result, which was consistent with trisomy 21, which had already been diagnosed by karyotype. So their conclusion from this paper was that CMA has quite low diagnostic utility in the setting of non-immune fetal hydrops, regardless of concurrent structural anomalies. So CMA might not be our most useful test in this setting. These are two other papers, both from China, and also looking at similar cases. So one looking at 129 cases, where they confirmed one additional case of an abnormal CMA compared to karyotyping, but they concluded that this was a benign copy number variant because it was maternally inherited from a well mother. The other study looking at 109 cases of non-immune fetal hydrops, they found a 4% pathogenic or likely pathogenic copy number variant on CMA after normal karyotype, but they stated that some of these copy number variants were not clearly associated with the phenotype of non-immune fetal hydrops and might be an incidental finding in this cohort. So if CMA is not useful, then of course we proceed with looking at exome sequencing, and we heard a lot about exome sequencing today already. This is a paper by Mark Kilby's group, specifically looking at fetal hydrops and the incremental yield of next generation sequencing. They did a small study and then also included a meta-analysis of more than 21 studies, and they looked at the pooled incremental yield of these techniques. And they found that there was an incremental yield of 29% in all non-immune fetal hydrops cases, and that was higher if we looked at those with structural abnormalities, and up to about 39%. And the main problems that they found was rosopathies. Rosopathies accounted for about 30% of these cases. Next commonly, musculoskeletal disorders in about 14.6%, and lower yield on inborn errors of metabolism. The predominant inheritance pattern seems to be autosomal dominant, but most of these were found to be de novo rather than inherited. This is another study looking at what kind of meta-analysis, systematic review, what kind of diseases were found when we proceed with exome sequencing. They had a 37% diagnostic rate, and they showed that 24% of these were due to rosopathies, 21% neuromuscular disorders, 17% metabolic, 13% lymphatic, and a lower percentage of other problems such as cardiovascular, hematologic, skeletal problems. Now there is a debate as to whether we should do exome sequencing or targeted gene panels. We all know that cost is an issue, and exome sequencing is expensive. Okay, so should we perform targeted gene panels rather than exome sequencing? And this is a paper from the UCSF group again, looking at 127 pregnancies. Okay, they performed exome sequencing, and they showed that 37 of these, about 29%, had pathogenic or likely pathogenic finding in 29 genes on their exome sequencing. Another 12 cases had a VUS, which was strongly suspected to be associated with the phenotype. They then looked at 10 relevant targeted gene panels, and they compared which of these conditions would have been picked up if they had used a targeted gene panel instead. And they found that 19 to 24, which comprises between 50 to 60% of these pathogenic variants, would have been detected if they had used a gene panel instead. So the yield is, of course, only about half. Okay, so about half of the when they looked at a specific fetal hydrops panel, the yield was higher, about 57 to 62%. When they looked at metabolic panels, only about 11%, with a higher yield on the resorptive panel, about 39%. So their conclusion was that targeted gene panels are probably not so useful. However, there is of course some criticism because it depends on the underlying etiology, and there is some question as to whether we should aim to phenotype the fetus better on ultrasound before we decide to do an adequate test, because not all hydrops is equal, as I showed many rows leading to Rome, and maybe we need to get better at looking at the different phenotypes or splitting them up into different phenotypes, and if we do manage to do that and we choose the appropriate panel, our yield might be better. So, for example, there's a study looking at fetuses that was suggestive as having skeletal dysplasia on an ultrasound, suggestive of as a cause of non-immune fetal hydrops, and if in those cases, if a skeletal dysplasia panel was ordered, it would have probably picked up most of these cases. Now, we said before that exome sequencing is expensive, and that's very often the reason why we don't use it as a first-line test. So this group came up with looking at cost effectiveness of exome sequencing. This is again the UCSF group, and of course this is on the background of their healthcare system. So when we're looking at about cost effectiveness, of course we need to take into account your own local setting and your healthcare costs. Okay, their primary outcome was looking at incremental cost per quality adjusted life years, and they felt that exome sequencing in the context of fetal hydrops was cost effective compared to no additional testing, compared to targeted gene panels, and also cost effective in a setting without the option for termination of pregnancy. And so in their conclusion, they said that exome sequencing should be considered for all cases. Of course, if we can check the exomes, why don't we check the whole genome? And this is one paper quite recently published looking at whole genome sequencing in 23 cases of non-immune fetal hydrops without the diagnosis. So they had normal karyotype CMA, they did not have exome sequencing. And they showed that half of these had a molecular diagnosis on whole genome sequencing. And they mainly found 7 genes with pathogenic or likely pathogenic variants. Mostly these were resorpathies, but there were also one case of GM1 gangliosidosis and IPEX syndrome. So I think this one is something to watch this space. I'm sure that more evidence will become available on this. Of course, these are quite small numbers. There's only 23 cases that they looked at, so there might be some bias. So the answer might be either to go for whole exome sequencing as a primary test, okay, or of course we could do sequential testing, and this is paper from China again that looked at sequential testing for patients with non-immune fetal hydrops. And they had 109 patients that underwent sequential testing, and 19 of those had an abnormal result on their qPCR karyotype. The main diagnosis for this were our traditional Turner syndrome, trisomy 21, trisomy 18, which we would expect. 72 patients then had a normal result and underwent chromosomal microarray. A further 4% had a pathogenic or likely pathogenic copy number variant, but some of these were not clearly associated phenotype. And then they went on to do WES for 21 patients, and 14 of those had a diagnostic result. So one option is, of course, to offer this sequential testing like this. You might prevent some, or you might save some cost for going straight for ES, but of course, time might be an issue because this takes time, okay? And of course, every test on its own costs. So what's the prognosis when we diagnose fetal hydrops? We know that the prognosis is generally poor, okay? Overall perinatal mortality rate of babies diagnosed with this condition antenatally is still in the range of about 50 to 98%. Of course, it depends on the etiology, on the gestational age of onset. We know that the earlier we diagnose it, the worse the outcome. The gestational age of delivery, of course, additional prematurity will affect the outcome for the baby, and the presence of pleural effusions because there is a significant risk of non-hypertension. What's the importance of antenatal diagnosis? I think we've had this many times today, but the importance, of course, is adequate counseling, antenatal counseling of the patient to give information on the survival, the worries about the developmental delay, comorbidity, quality of life, as well as the possible required postnatal treatments. Other things is, of course, that prenatal management might differ. So, for example, we diagnose fetal anemia. We have possible treatment options available. Other things we can do is we can shunt fluid to help with the risk of lung hypoplasia. So there are antenatal interventions that we can offer. Of course, it leads to adequate delivery planning and perinatal management. So parents are given the choice of active or not or palliative care. And prompt neonatal treatment might be in place if required. Okay? And as we said before, accurate counseling on the current risk. So this is my summary slide, which basically comprises what we have gone through just now in detail. When we're offering advanced genomic testing, of course, MDT discussion is important to select the appropriate test. Now, I just shared two quick cases with you from our hospital, okay, which hopefully illustrate some of these principles that we've learned. So the first case is a 25-year-old lady in her first pregnancy. She booked early and her booking bloods were normal. She opted for first trimester screening, and at her 12-week scan, the fetus was found to be hydropic. So you can see the NT was significantly thickened at 11.8 mm. There was edema all around the fetal head and body. There was evidence of heart problems, so there was suspected hypoplastic left heart with a single inflow and a single outflow tract. There were bilateral pleural effusions, ascites, as well as bilateral transfusion. She had a CVS, and she opted for karyotype, and the karyotype came back as showing a cytogenetically unbalanced female karyotype with material of unknown origin attached to the short arm of the So when she came for her results, she had a rescan to confirm the findings as per her wish, okay, which still confirmed fetal hydrops, reconfirmed the hypoplastic right heart, lower limbs were fixed in a flex position, she had bilateral cup feet, echogenic kidneys, and the bladder was not seen. The patient opted for termination. The second case is a 37-year-old lady. She is a Paravan. She had a previous normal delivery at 36 weeks, followed by a first trimester miscarriage. Again, she had normal booking bloods. She went for first trimester screening, which was low risk, and she was referred to our unit at 25 weeks for the final incidental finding of fetal hydrops on ultrasound scan. These were her findings when she came to us. So the fetus was normally grown, the AFI was normal, there was presence of bilateral pleural effusions, the right mid-medius shift, there was no ascites, but the chest wall appeared thickened, 8.4 millimeters with minimal scalp edema. The MCA-PSV was normal. She underwent the left thoracocentesis, and the sample was sent for fluid profile, differential count, cytology, CMP, toxo, and parvo screen, as well as chromosomal microarray. She declined LUES. Unfortunately, the next day, the pleural effusion had reaccumulated, okay, but the result of the differential count suggested that was mainly lymphocytic in nature, and the infection screen came back as normal. 1 week later, she underwent a fetal thoracoamniotic shunt insertion, which unfortunately was displaced the next day, and she had received neonatal counseling and had admission and opted for full active resuscitation. We re-attempted the shunt insertion and amnion drainage the next week, which was successful, okay, and at that time chromosomal microarray came back as well, which was normal. Okay. The patient was agreeable for DNA extraction and sending the sample for exome sequencing. At 28 weeks, the baby still continued to grow normally. The left lung was now fully expanded with the shunt in situ. The right pleural effusion was still present. There was no ascites. Okay. So it looked more promising at this stage. However, the shunt was placed again and the pleural effusion reaccumulated, and she developed more significant skin edema. And despite attempting a reinsertion of the shunt, this was unsuccessful and only amnion drainage was done. She presented in preterm labor at 30 weeks, and a baby was breech. As she wanted full active resuscitation, she had an emergency cesarean section after completion of magnesium sulfate. The baby was born in poor condition with a poor APGAR score, was immediately intubated and had chest tubes inserted, but because of deteriorating condition in the NICU, the couple decided for terminal extubation on the first day of life. Only after the demise of the baby, the exome sequencing actually returned, and it showed a pathogenic variant in keeping with Noonan syndrome, which was actually maternally inherited. So the mother was confirmed to be a carrier of the same condition, and she has since been appropriately referred for her own investigations. So that concludes my talk, and I'm happy to take